Welcome to this short video on catastrophic maxillofacial bleeding. My name is Lieutenant Colonel James Ginnery and I'm an Army consultant in anaesthesia and pre-hospital emergency medicine here at UHCW. Historically, the incidence of cranial maxillofacial injuries has decreased following the introduction of seatbelts, helmets and airbags. Unfortunately, these injuries are now increasing again, primarily due to interpersonal violence, which makes up 50% of these serious injuries. Road traffic collisions, sports injuries, falls and industrial accidents make up the remainder. The facial bones are the crumple zone of the cranium and can result in classical Fort fractures of the middle zone, or other fracture patterns can occur. Blunt trauma can fracture the maxilla and result in arterial bleeding from the underlying internal maxillary artery and intraosseous branches. This bleeding can be catastrophic in nature. In the awake patient, bleeding from the maxilla can sometimes be hidden if the blood is swallowed, and there can also be associated cervical spine injury and/or intracerebral hemorrhage, particularly if the patient has been subject to assault with multiple impacts to the face and head. It's worth noting that as the tongue is tethered to the mandible in the unconscious supine patient, this can easily drop back and obstruct the airway. The same can happen with an unstable maxilla. So when conscious, patients with these types of injuries will often self-adopt a sat-up, face-forwards position, particularly to allow blood to drain from the airway and ensure its patency. This should be recognised and maintained until the point of intubation. These patients present a particularly challenging group as they may have both a difficult airway, an unstable cervical spine, and a traumatic brain injury, and poorly tolerate the supine position for whole body CT. The RSI of these patients will be difficult. Therefore, in order to anticipate this, the most senior TTL, anaesthetist and surgeon able to undertake front of neck access should be present. Postural drainage will need to be maintained up until the point of intubation, and it may be preferred to move the trauma team with the patient to theatre in order to provide the most optimal equipment and environment in order to secure the airway. Once the patient has been safely intubated, the facial bones can be splinted using the maxillofacial bleeding stabilisation kit. Located in the resus room equipment corner cupboard, the maxillofacial bleeding stabilisation kit consists of two 20ml syringes, two 10ml syringes, 80ml of saline, two single-use bite blocks, two single-use nasal epistat catheters, and one adjustable hard collar. Before use, the equipment should be organised on a tray accordingly with the saline drawn up. It is not necessary to test the epistat balloons before insertion. Once intubated and the ET tube has been tied, put the spine collar behind the patient's neck, but don't close it at this stage. Insert the epistats bilaterally, but do not inflate them. First, you need to insert the bite blocks. This is in order to splint the maxilla onto the base of the skull, and then close the cervical spine collar. The last step is to inflate the balloons on the epistats. The distal or posterior balloon needs up to 10 ml of saline, and the injection ports are marked accordingly. This injection should be done simultaneously, and then with gentle traction, the anterior balloons inflated with 20 to 30 ml of saline. Again, ideally, this is done simultaneously. The bite blocks instructions for use are hyperlinked from this QR code on the video if you wish to study this further. There's now a short demo of how to use the kit on an airway mannequin. Right, so we've got the patient intubated, and Dina, you're continuing manual inline from the top end. Rich, we're going to get the Max-Fax bleeding kit out. You've prepped it, that's brilliant, thank you. So we've got the epistats with the distal and proximal balloons, and we've got the bite blocks which are going to go in, and we've got a collar which we've put in place behind the patient's C-spine. So we're going to get the epistats in now, and they go in very much like NP airways, following the base of the nasal passage, going horizontally, and the balloons have got amounts on them to remind you how much to put in the balloons, but we're not going to inflate them just yet. Next item that goes in are the bite blocks. These are single use, and they've got anti-swallow devices on them. There's no chain so as not to interfere with the CT scan. So Rich, do you mind just opening the mouth slightly for me, mindful that the mandible may well be in bits, and what I'm trying to do is seat these so that the molars are in the groove of the bite block. So again, they go in, get to the back, and then a little twist so that the molars are seated on the grooves. That's brilliant, Rich. If you can close the mouth now. We're going to close the collar, and then lastly inflate the epistat balloons. So we've got 10 mils of saline for each of the distal balloons, and it's marked as 10 mils, and we're going to inflate that together. 3, 2, 1, inflate. Mindful there may be a little bit of loss because it's a lure push connector. And now the proximal balloons. 3, 2, 1, inflate. And if we need to add in an additional 10 mils, the balloon has got a 30 mil capacity, but may only require 20 mils, depending on the size of the patient. So, epistats in place, bite blocks in place, collar closed. We're going to get the head blocks back in and straps now. Thanks, Dina. Okay. Cheers, Rich. We've got the straps. And now we can go to CT once they're ready. Thanks for watching the demonstration. You should now know where the equipment is located in the ED Recess Trauma Bay cupboard, and how to use it in patients with catastrophic maxillofacial bleeding. A set of training kit is available from the lead recess practitioner for those that require it, and it's also possible to undertake a simulation on one of the major trauma simulation sessions in the CSB. Thanks for listening.